Every cell in the human body relies on a highly conserved 8-step biochemical assembly line. Successive enzymes take simple precursor molecules, modify them, and pass them down the chain until a final, vital structure locks into place: heme. When this assembly line functions perfectly, heme oxygenates tissues, detoxifies drugs in the liver, and powers cellular respiration. But when genetic mutations introduce partial blocks into this sequence, the intermediates back up. This generates the Porphyrias, a group of 8 distinct diseases that present a striking clinical paradox. Errors in this exact same metabolic pathway can cause radically different, seemingly unrelated emergencies. Some patients present with life-threatening acute neurovisceral crises. Others present with severe, blistering cutaneous dermatoses. The phenotypic split depends on where the assembly line breaks. Early-stage failure causes small, water-soluble precursors to accumulate, flooding the nervous system and driving neurotoxicity. Late-stage failure results in larger porphyrin rings that migrate to the skin, absorb ultraviolet light, and trigger intense photosensitivity. To diagnose and manage these conditions, we have to construct the complete metabolic pathway from start to finish. We will isolate the specific rate-limiting bottlenecks and decode the diagnostic algorithms used to differentiate all 8 porphyrias. By mapping the precise spatial location of each biochemical block, we replace brute force memorization with predictive mechanical logic. This diagram outlines the spatial architecture of heme biosynthesis. The 8 enzymatic steps are divided across 2 cellular compartments. The first and last 3 steps operate inside the mitochondria, while the middle 4 occur out in the cytosol. Step 1 is ALA synthase 1, or ALAS1. Located deep within the hepatic mitochondria, this enzyme dictates the speed of the entire system. It is the primary rate-limiting engine. Under normal conditions, ALAS1 is strictly governed by a negative feedback loop. As the pathway produces free, completed heme, that heme represses the production and activity of ALAS1, maintaining exact cellular homeostasis. External triggers can easily break this loop. CYT-inducing drugs, like barbiturates or certain antibiotics, and fluctuations in sex steroids rapidly increase the liver's demand for heme. To meet this demand, ALAS1 undergoes massive upregulation. Caloric restriction and fasting also act as potent triggers. Dropping glucose levels induces a transcription coactivator called PGC1-alpha, which forces ALAS1 to accelerate production. Physicians must identify these specific inducers to prevent a clinical crisis. Accelerating the ALAS1 engine against a downstream partial block forces metabolites to crash, serving as the catalyst for an acute attack. Looking at this flowchart, we locate step 3 in the cytosol. The enzyme here is HMB synthase. An autosomal dominant deficiency at this exact site results in acute intermittent porphyria, or AIP. In AIP, this enzyme functions at only half capacity. When ALAS1 is induced by fasting or drugs, the compromised HMB synthase cannot process the sudden influx. The result is a massive bottleneck, causing early precursors, specifically ALA and PBG, to backlog aggressively. This specific early-stage accumulation yields entirely neurovisceral consequences. Patients suffer severe, poorly localized abdominal pain caused by an intestinal ileus, accompanied by extreme autonomic sympathetic overactivity, driving their heart rates and blood pressures dangerously high. The neurological threat rapidly compounds. It typically begins as a proximal motor axonal neuropathy in the shoulders and arms, but left unchecked, the damage can ascend to bulbar and respiratory paralysis. Because this metabolic block occurs so early in the sequence, complex porphyrin rings are never synthesized. Without intact porphyrins to migrate to the skin, an AIP patient will definitively never present with cutaneous lesions. To reverse this crisis, physicians must break the assembly line. Administering intravenous hemin artificially restores negative feedback on the ALAS1 engine. Alternatively, a targeted RNA interference therapy called givosiran can directly silence hepatic ALAS1 mRNA, stopping precursor production at the source. Early enzymatic blocks in the liver produce purely internal neurovisceral crises by flooding the nervous system with toxic precursors before photosensitive compounds are ever built. Here, the diagram shifts further down the cytosolic pathway to step 5, urodecarboxylase, or UroD. A block at this site causes Porphyria cutanea tarda, the most common of all the porphyrias. Because this disruption occurs late in the assembly line, the early neurotoxic precursors, ALA and PBG, are metabolized successfully and do not accumulate. Consequently, PCT entirely lacks the acute neurovisceral attacks that define AIP. Instead, large uroporphyrinogen molecules pool behind the block. These oxidize into uroporphyrins, enter the blood plasma, and deposit heavily in the skin. When exposed to sunlight, they generate reactive oxygen species, causing severe blistering, scarring, and facial hypertrichosis. This specific enzyme is uniquely vulnerable to oxidative stress in the liver. Conditions like hepatitis C infection, excess alcohol consumption, and hepatic iron overload all act to inhibit UroD function, triggering the disease. The treatment strategy leverages this mechanism directly. By executing regular therapeutic phlebotomies, physicians drain total body iron stores. Removing this excess hepatic iron relieves the oxidative inhibition on the UROD enzyme, allowing the pathway to clear the backlog. Late-stage hepatic blocks spare the nervous system, but weaponize ultraviolet light by turning accumulated porphyrins into destructive phototoxic agents directly inside the dermal layers. The clinical picture changes completely when the anatomical origin shifts. While the previous conditions were driven by hepatic enzymes, erythropoietic porphyrias originate from massive porphyrin overproduction inside the bone marrow. A defect at step 4, UROS, causes congenital erythropoietic porphyria, or CEP. Without functional UROS, the pathway fails to assemble the normal asymmetric molecules and instead dumps massive quantities of non-physiologic type 1 isomers into the system. The resulting phenotype is extreme. Patients suffer severe, mutilating cutaneous blistering immediately from birth, complicated by chronic hemolytic anemia. Most distinctively, they present with erythrodontia. Their teeth are permanently stained brown and will fluoresce bright pink under an ultraviolet Woods lamp. If we move the block to the absolute final step in the mitochondria, step 8, ferrochelatase, we encounter erythropoietic protoporphyria, or EPP. Here, the marrow fails to insert iron into the finished ring, resulting in a systemic buildup of protoporphyrin IX. Clinically, EPP breaks the expectations set by other cutaneous variants. Unlike the others, it causes zero blistering. Instead, patients experience excruciating, immediate burning and tingling within just 10 to 30 minutes of sun exposure, followed by painful swelling that resembles angioedema. When the assembly line fails in the bone marrow, the sheer volume of continuous porphyrin production creates a lifelong state of immediate phototoxicity that completely eclipses the intermittent, trigger-based nature of the hepatic variants. This decision tree outlines the diagnostic algorithm for acute attacks. A patient with severe neurovisceral pain and elevated urinary ALA and PBG could have AIP, HCP, or VP. They present identically. To disambiguate the specific enzyme block, we must test a different biological matrix. The definitive differentiator is fecal porphyrins. Fecal porphyrins will be perfectly normal in AIP. They will show elevated CoPro-3 in HCP, and they will reveal elevated proto-9th alongside a unique plasma fluorescence peak in VP. Now look at this second tree for a patient whose labs show elevated erythrocyte protoporphyrin. This finding alone is ambiguous. It could indicate EPP, lead poisoning, or severe iron deficiency. The mandatory next step is to test the chemical state of the compound. In EPP, the protoporphyrin is entirely free of metal binding. In lead poisoning and iron deficiency, the cell compensates by inserting a zinc ion, making it exclusively zinc-complexed. The presence or absence of an acute crisis separates the blistering phenotypes. Purely cutaneous symptoms without neurovisceral involvement define PCT. When blistering occurs alongside acute attacks, the pathology narrows specifically to HCP or VP. Clinical mastery of the porphyrias requires abandoning static lists of symptoms. Diagnosis requires a precise understanding of cellular compartments, enzymatic bottlenecks, and targeted biological matrices to decode the patient's exact metabolic failure.